Sammy, you can go to that white page and make your that 4 or 6 the thing.
When shall we start now?
Uh, are we waiting for somebody?
No, no, no.
Okay. You can go to that white page.
Can you see it now?
Yeah, I can see. You can you make it like 4 tabular columns or 6 tabular columns?
If you
Of
make
your
the table, I am not able to write in that. I have to make it.
sorry, I don't get you.
1 second.
Yeah, yeah, yeah.
Okay.
Yeah.
The thing is, if I type something in this and then I make a new column, I cannot again add it.
Yeah, yeah, I know, I know, I know. Yeah. 1 second. So, can we go ahead?
Yeah.
Yeah, okay. This is a 19-year-old male
Okay.
complaining of chest pain.
Okay. Receive him to the red area. Connect him to monitor. Put
Okay,
two labs for IV cannula. Draw bloods for test and
okay.
start him on O2 via non-breathing mask.
Yeah, I started.
So is he talking in full sentence?
Okay, yes. But he seems very uncomfortable.
Is he in any pain?
Sorry?
Is he in any pain?
He's anxious but alert. He's uncomfortable.
Uncomfortable. Okay. So how is his work of breathing?
Work of breathing is increased.
Increased. Okay. Respiratory rate increased.
What?
Respiratory rate
Respiratory rate is around 18.
18. Saturation
Saturation is 99% in room air.
10%. Okay. So his heart rate and BP.
His heart rate is 100
Okay.
and his BP is 110 by 60.
Something like 60. Okay. Capillary refill is normal.
Yes, capillary refill is normal.
So you said he's alert, right?
Yes, he is alert, but
But
he's not okay. He doesn't look okay.
okay. So like
He looks
and
very uncomfortable and anxious.
okay. GRBS.
His GRBS is 110.
Then okay. Pupil sequel.
Okay.
Is he having a temperature?
Temperature is normal, 37.8.
Okay. So his primary survey looks okay, but he is uncomfortable.
Sorry?
His vitals are normal, but he is uncomfortable.
Yes.
Okay. So, can I ask when did the pain start?
Actually, he is in the morning. It's a sudden onset burning chest pain.
Okay. One second, please. When did it start? What was he doing?
He was simply watching TV, and he was actually playing video games with his brother.
Okay. So only like where is the chest pain?
Sorry?
I mean, is the pain and on the entire chest?
Yes, it's on the chest.
Okay. Central chest pain.
More in the central chest.
Okay. So anyway, we'll take a 12 ECG.
Yeah, we will take one.
Okay. So meanwhile, we'll get more history.
Sorry?
We'll take a 12 ECG. Is it available
Okay, we will take. The ECG machine is on the way.
on
Not
the?
yet ready.
Okay. So along with chest pain, is it uh, increasing now?
Along with the chest pain?
Is chest pain increasing now?
Yes.
Okay.
Yes. The chest pain
Okay.
is so much for him.
Is it radiating anywhere?
Sorry?
Is it radiating anywhere?
Yes, it is radiating to his shoulder, left shoulder, and also to his back.
Okay. Fine. So what is his pain score?
The pain score is 10 by 10.
1 by 2. Is he allergic to any medications?
No.
So, uh, I'll give morphine for pain relief. I'll start
For
with 3
pain
mg.
management, you want to give morphine. How much?
I'll start with 3 mg and I'll titrate according to pain relief.
Okay, 3 mg morphine given.
Okay. And I'll hang a 1 liter NS bolus, normal saline bolus.
You want to give like 1 liter of what?
Normal saline. And,
Normal saline. Bolus given.
okay. Okay. So after pain medication, how is his pain now?
Little bit better. He's relieved little,
Anxiousness has
but
improved.
still continue to having pain.
Okay. But anxiousness improved. His like,
Um, he's little bit. Yeah, everything has been subsided to 10 to 20%.
okay. Fine. So we'll titrate morphine for pain relief,
Okay.
and then we'll go for the history, the sample history.
Okay.
Okay.
Yes.
Can you hear me?
Yes.
So there is chest pain
Okay.
radiating to what?
Radiating to the left shoulder and back.
Left shoulder and left. Okay. It's how what is the quality of the pain? Is it a heaviness or is it a pricking type of pain or is it a
He
straight?
can't tell actually. He's in a lot of pain and he can't talk. How's it? So he feels it's very heavy.
Okay.
Actually, he can't tell you what it is, kind of.
Okay. Okay. Is there any associated symptoms with pain?
Yeah, he was vomiting actually. He had like 3 to 4 episodes of non-bilious vomiting.
Vomiting. Okay. So after the vomiting, his pain started.
Yes.
Okay.
No, actually, he can't say that.
Okay. So fine.
He was feeling some discomfort,
Okay.
and followed by he was like having this vomiting. Actually, he had this vomiting in the night also, like 2 to 3 episodes, and he is now also having in the morning.
All right. Okay. 3 to 4 episodes of vomiting, non-bilious, non-bloody.
Yes. Yes.
Okay. Any sweating, any palpitation, any
Yes, he is diaphoretic.
okay, any palpitation, syncope, breathing difficulty,
No, no palpitation.
no syncope, no breathing difficulty.
No, nothing like that. No history.
Okay, so only vomiting and chest pain.
Yes, only vomiting, and now you because of you gave morphine before asking these symptoms, he's puking like anything.
Okay. So I'll give antiemetic also injection emisset 4 mg IV stat.
Okay, you want to give 4 mg or
Yeah,
Odansetron.
ondansetron. Yes.
Okay, given.
Okay. And I'll give a pantoprazole 40 mg IV also.
Okay, pantoprazole 40 mg IV given.
Okay. So there is vomiting, chest pain. So like what was his like any food intake, like any other unusual food intake or any? Or,
He was just came off from his friend's party last night.
okay. So was he taking alcohol?
Yeah, he did have some.
Alcohol binge or no?
What?
Did he take a lot of alcohol?
He says a little.
No allergies, right? So had alcohol binge. Had alcohol.
Yes, he had alcohol. He had a binge.
Okay. So is he on any medications?
Yes. He was actually having a psychiatric disease, like he was suffering from depression and anxiety. So he was on paroxetine and clonazepam.
Paroxetine, clonazepam.
Yes.
When was his last meal?
Sorry?
When was his last meal?
His last meal was he had that in his party.
Yesterday night. Okay. So social history wise, he has alcohol intake.
Yes, he had alcohol intake.
Is he a smoker?
What?
Is he a smoker? Smoker.
No, no, no. He doesn't smoke. He's 19-year old. His parents are telling you this, okay? He doesn't smoke.
So he's staying with his parents.
Yes, he's staying with his parents.
Okay. So he's having psychiatric illness also.
Yes, he have some.
Okay. Any family history of heart disease?
No, no significant family history.
Mhm. Okay. So here we have a 19-year-old male known with
Okay,
psychiatric disease,
okay,
depression on paroxetine and clonazepam.
okay,
Came with complaints of chest pain, sudden onset chest pain
okay.
relating to back and shoulder.
Mm-hmm.
Also had 3 to 4 episodes of non-bilious vomiting
Mm.
after, and he had a history of alcohol binge yesterday night.
Okay,
So we have given him, we have started him on O2. We have collected bloods. We have uh, given him pain medication. We have given him antiemetics and
okay,
fluids.
okay.
Okay. So at this point, is the ECG available?
What? ECG?
Yeah.
Yeah, ECG is available.
So can I see that?
Actually, ECG is showing only sinus tachycardia. Sorry, I don't have an ECG.
Uh, okay. Sinus tachy.
Yes.
Okay. So how is his pain now?
Pain was little bit okay.
Okay. And what about his this thing, vomiting?
Vomiting, he still kind of feel like puking, but he didn't vomit after you gave emesit.
Okay. We'll go for head to toe examination. So,
Yes?
okay. So in head, any abnormalities? Head, eyes,
Any
ears,
head abnormality you're asking me?
scalp, any laceration?
No, 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 no history of trauma.
No. Okay. Eyes, any pallor, any stress,
No, yeah, he's mild pale.
pain. Okay. Ear, nose, throat.
Ear, nose, throat, all normal.
Okay. In the neck, any distension, J, JVP distension.
Sorry?
In the neck, any jugular distension.
In the neck, there is no jugular distension, but I see some kind of an erythema in the neck and the chest, in the upper chest.
Erythema.
Yeah, kind of a redness.
Okay. So when is it warm to touch? Any when we touch?
What?
When we touch it, is it warm? Is it warm?
Yeah, it is warm.
Like any
Actually, because of his diaphoretic, and now when you touch, it's like chill.
chill. Okay.
But is his extremities are not cold? Okay.
Fine. So
Okay.
he
Now his
the
BP
whole
is
thing.
dropping. Now his BP is dropping. You already gave him 1 liter of fluid. Now his BP is dropping.
Okay. So there was alcohol binge and chest pain.
Okay.
Is there any crepitus?
You are auscultating the patient.
No, no, no. Just
Okay.
that erythematous area.
Yes, yes. You do hear a rice paper consistency.
Okay. So chest pain, sudden onset, severe chest pain following.
I don't know. I
Itching.
don't know. The patient doesn't know when it happened. You're just seeing it
No,
now.
I'm telling sudden onset pain along with vomiting in a 19-year-old and
Okay.
alcohol binge is there. So
Okay.
we have to suspect a esophageal rupture for this patient.
Okay. So you have a X-ray. Sorry.
Amma.
Okay, you have an X-ray. The X-ray looks fine except for the increased hilar shadows, increased hilar bronchovascular markings,
Okay. So
and you see left-sided pleural effusion.
pleural effusion. Okay.
Yes, left-sided pleural effusion, and you see widened mediastinum.
Okay. So we'll complete the second the head to toe examination and then we'll get the consult with.
Okay.
Okay. So in the chest, how is the air entry?
Air entry is heard well.
Well, any chest wall tenderness or any.
Per se, there is no chest wall tenderness.
Okay. Abdomen. Is it how is the abdomen?
Uh, Abdomen, what do you want to know?
Is it soft? Is it tender?
It is soft.
Is there any tenderness?
No,
Yes. Vowel sounds? Is it
heard,
third? Okay. And external genitalia
normal.
and
He have one undescended testis. It's okay.
uh-huh. And what about this
What
extremities?
about
Extremities.
what?
Extremities. Is extremity.
Extremities. I told you it's normal. It's warm.
Wow.
I told you he's dropping his BP 10 minutes back. Now the patient is becoming drowsy, more stuporous.
You said he's becoming hypotensive.
What?
You said he's becoming hypotensive.
Yeah.
Okay, so we'll give one more bolus of normal saline.
Okay. On flow.
Okay. How is the response?
Now the patient is complaining of so much of pain, and he's puking again. And now he's puking blood.
Blood down.
Yes.
Okay. So uh,
Now his heart rate is going up to 130, 130 per minute.
okay. We'll send for blood
Uh,
count.
okay.
Count.
So you didn't send the sample still?
No, no, I didn't send.
Okay. While putting the Venflon, you didn't send the samples. Okay.
And soon I
Send.
had taken samples.
Okay. What
Okay.
all you want to know?
I'll send for a complete blood count,
Okay.
electrolytes,
Okay.
troponin I,
Okay.
and like since now he's puking, we'll go for a blood grouping and arrest taking.
Okay. So that's all you want to know? That's all. I mean, that's all you want to send?
Yeah, and coagulation profiles also will send.
Okay, coagulation profile. Whatever you asked for, all has been sent.
Okay,
Okay, you have 3 minutes more to complete the case. The patient BP is dropping.
okay. How is it? How is he responding to this thing?
No, he's not responding.
Okay. We'll start him on vasopressor,
Okay, what do you want to start on?
noradrenaline.
Okay, now the saturation is dropping. The saturation is going to 80, 82.
Okay. So even with oxygen, his DCS is
You
also
never
good.
put him on oxygen.
Yeah, I started him on O2 from the
Oh,
beginning.
that is him on water. When the saturation was 99, huh?
Yeah, like in the beginning itself.
Okay, so he is on high flow, but still his saturation is 82.
Okay, so he's stuporous also.
Mm? Yes, he's becoming stuporous, deeply stuporous.
Okay, so I'll have to speak with the bystanders and then I'll have to decide on uh,
You don't
intubating.
want to go near the patient?
Pardon?
You don't want to go near the patient?
Yeah, I have to speak to the bystanders and I have to decide on intubation.
You want to intubate the patient?
Yeah,
Okay, go ahead.
okay. So let me speak to the bystanders.
Yeah, please.
Okay. So I'm Dr. Sami. I'm,
Okay.
I'm seeing your son. So he,
May I know what's happening with my son?
yeah, so he had a history of alcohol intake. He had alcohol binge yesterday night. So I was told that he had multiple episodes of vomiting and he had a sudden onset chest pain today morning.
Okay, doctor, he's a 19-year-old kid. He very rarely takes alcohol. He's not an alcoholic. Okay, to get to chest pain because of alcohol. I'm sorry if I'm interrupting for this, but I don't think whatever you're telling is not convincing me. How a 19-year-old, after get having a very binge of alcohol will get a chest pain of out of this proportion. I can't get your point. Sorry.
Okay. So thing is when we have multiple episodes of like when we vomit multiple times, so patient might retch many times. So that time there might be the we have the food pipe, we call it as esophagus. The pressure inside that might increase and it may rupture. So it can happen with anyone with multiple episodes of vomiting, not always associated with alcohol intake.
You have 1 minute to complete the case.
Okay.
Patient is dropping. Patient became arrested. Patient arrested.
Okay, then start CPR.
Okay.
Okay, and what is the initial rhythm?
Initial rhythm is VF.
We, so bag wall masking also,
Okay.
and uh, connecting to
What?
defibrillator, and
Okay. You want the
give,
defib. Okay.
give he's on VF, right?
Yes, it's on VF.
Okay, so we can give him 200 joules unsynchronized
Okay.
dose.
200 joules charged. Everybody clear? Shock delivered.
Okay, resume CPR for 2 minutes,
Okay.
and then after 2 minutes, recheck the rhythm.
Okay. You have an organized rhythm on the screen.
Okay, is there any pulse?
No?
No pulse.
Yes.
Then restart CPR again.
Okay.
Give epinephrine 1 mg.
You will give what?
Epinephrine.
Yeah, 1 mg of epinephrine given.
Yeah, and
And your time is up. And the patient has been declared. Sorry.
okay.
Okay. The thing is, you almost you got the diagnosis. Okay, you got my point exactly, and you did. It says bore hips. I know it's a very tough one. Mm, the thing is, if you follow this, the so-called ritual, what they do in a temple, like, I'm sorry, being an Hindu, I know only this. So whenever you see like Hindu temple, how they worship the god, they won't put everything on the god's head. They have a system. They will put water, they will put chandanam, and then put the curd. They have a system of it. Same, the patient should be examined in the same way as a ritual. You won't skip steps. So you did A, B, C. In B, did you auscultate the patient?
Where?
In B,
The pata. So,
did you auscultate the patient?
no, no. I thought I'll do it in the head-to-toe examination.
How will you like how will you think you will do it in the head-to-toe examination? No, the auscultation of the patient comes in B.
Okay.
Then what about while auscultation? Won't you touch the patient and see?
Pardon?
While auscultating the patient,
Ah,
won't you touch the patient?
yes, yes.
Yes. And while asking the any pain, won't you go with Socrates?
Yeah, I went, no?
Yeah, but it was done very late. The pain score, the associated before even you are giving any analgesia or intervening the pain, before only you have to do Socrates, right?
I asked, like,
No,
what in this Socrates format, I have asked for the quality
you
of
did
food.
ask. You did ask before even giving morphine. You didn't ask.
Okay,
Okay, so before intervening any pain, just like that, if the patient says pain, you can't give any analgesia.
okay,
You have to know about the pain first.
okay.
Then only you can decide on what kind of analgesia you can offer for the patient. So just because you heard pain, you gave morphine. You didn't ask about whether he had associated symptoms, vomiting. You gave morphine. Already vomiting patient, you usually don't give morphine.
Okay,
So he he vomited again. You caused more vomiting and more of damage.
okay.
Okay, then. And what else? Okay, whenever you put the IV line, you will send samples.
Yeah, the thing is for our oral boards, we are expected to take the samples that time and then send
You
the.
have to verbalize. See, we are doing this in a very virtual platform, so we don't know.
I have verbal. I have told I put two large for IV cannula and colored bloods for investigation.
Okay, you said probably I didn't hear. Okay, mm, and by the sample history, what all the history you elicited?
So, like the symptoms related to symptoms or the other complete.
Yes, always in oral boards, you have to ask about under which doctor they are, like physician, general physician, and with whom they are living. And you did ask about the past medical history and everything, but you did in the sample history, you have to elaborate about the event, the last meal. You asked about the last meal, the event. You asked in the first thing,
Ah,
like you should more elaborate about this, the pain or whatever brought to the patient to the ED.
okay,
So that was not done. And yeah, you did a secondary survey completely. At that time only you came for the skin, and it's good thing. And whenever I say the patient is collapsing, not me, whatever, patient is collapsing, the first priority is to resuscitate the patient, not talking to the attenders.
okay,
So whenever I say a problem in A, you should attend A. Whenever I say the problem in B, you should attend B. So when the patient was like desaturating, what should have been your first step?
I have to intervene.
He became stuporous and he desaturated. This is the open question to all people.
I have to intervene his airway and breathing.
Airway, you should have been done?
I have to assess the airway whether it is patent or like
Okay,
there
then.
any secretion, any obstruction.
Okay, see, the patient is stuporous. Okay, it means what?
He's not maintaining his airway.
Okay, what is the maneuvers you do?
He can go for a head tilt and lift.
Yes, that's what. Do
Okay,
it first. Increase the oxygen. Then whatever the damn work you do next. Okay. Then when I say the BP is dropping, what did you do?
I gave him another fluid bolus.
Okay. After that?
Started in one vasopressor.
Okay. Did you check the response? Fluid response, fluid challenge?
Yeah, I gave.
That's because the BP
Uh,
is not picking up. That is how you check the response of like fluid thing.
no, we have to check whether tachycardia is improving.
Yes. So did you verbalize that?
No, no.
Any kind of a fluid, whatever you give to the patient, you will check the response for the given fluid, even if it is 100 ml or 250 ml or 1 liter, whatever it is. You have to check the response if the patient is fluid responded or not. How many fluids can, like how many ml you can give if the patient is not improving with the fluid?
20,
Totally. In a
20,
resuscitation, actually.
20 ml per kg.
The new guidelines. It's 30 ml. Initially it was 20, now it has been 30 ml per hour, 30 ml per kg. And next, what line you would prefer? Like central line or a
Peripheral.
yes?
Peripheral.
Yes?
Pardon?
What line would you prefer? You would prefer a central line or a normal peripheral axis?
Like for immediate resuscitation, we'll go for peripheral. Then once
I
we
say the patient have central line too.
have the central line.
Yes, I was there on duty. I placed one.
Okay.
So what line you prefer?
Then we'll go for central line.
You go for central line. No, I say no.
Okay.
I want to fluid resuscitate the patient only by a peripheral venous access. The last class, where is this person? He didn't attend this class today. I forgot his name. What is his name? Who was the last presenter? Like what I moderated? What's his name? I forgot. Shahim. He's not in the class. Okay, find the answer for it. I prefer peripheral venous access for fluid resuscitation. Not the,
Large bore peripheral. Kanga.
yes,
Yeah. Okay. So there will be low resistance.
flow resistance. I asked about two laws to look up: Poiseuille's law and Laplace law. You people never did it. Okay, look up. And okay, so you suspected the patient to be on pneumomediastinum, but you wanted to intubate the patient on first place. Before that, what you want to do? Hello?
Hello.
Yeah. So you suspected a pneumomediastinum, right? And I also say like the X-ray is having pneumomediastinum. So you want to intubate the patient right away.
We'll have to see whether there is pneumothorax also.
Mm, yeah. Did you do a POCUS?
No, focus I didn't do.
You didn't do. Okay. So primary survey adjuncts. What are the primary survey adjuncts we usually take?
ECG.
We use what are the adjuncts? See, there are primary survey and secondary survey. We do have adjuncts in primary survey and secondary survey. Both are different. So you need to know what to be done on primary survey and what not to be done on secondary survey.
After primary survey, we can go for focus as adjunct.
Yes. What else you can ask for?
Needed ECG, we can go.
Sorry?
ECG if needed.
ECG, yes. Actually,
And
ECG comes in the secondary survey. I'm so sorry.
so even in a chest pain patient.
X-ray is one of the adjunct in the primary survey.
Okay.
Okay. Okay, yes. So you didn't ask for an X-ray. You didn't ask the patient, and so far, and other things are like I have. Yeah, we dealt with things. So you picked up the diagnosis. Actually, the oral board should end like you start, you have your action plan, you have your results, and you have your DD, you explain, and you finish it off and come. Okay, this is how you have only 10 minutes. So, whenever you're prompted about something, you have to go and intervene. That's it. So when you leave that thing, that is how you get, succumbed in those things. And when you know it is like, bore heaves, who all you should call, you should have called.
Gastroenterology,
Yes, gastro, then
cardiothoracic surgery,
yes, CTVS, and
and ICU.
okay, I see team. So are you so confident in intubating a
No,
19-year-old who's puking again and again?
no, I have to
You
get.
have to call a senior of your shift or the anesthetist on call. Okay. So, and what else you should have been done? Like you started fluid, you did everything. You should also consider anything else when you consider the patient is like having bore hips.
What else?
Okay. Ample history, 19-year-old guy, whoever it may be, who went for a party. Don't you want to elicit usage of illicit drugs?
Yeah, yeah, drug history.
So he became stupid. As don't you want to send a talk screen?
Yes, yes.
Okay. So when patient came with a chest pain, you wanted a ECG. So you don't want to send cardiac enzymes. What? Okay, chest pain. This case, what would have been your DD?
ACS,
What, darling? Sorry, I can't hear you.
ACS, ACS,
ACS first. Okay. Second,
uh, aortic aneurysm,
proportionate to pain.
aortic dissection,
Aortic dissection. Yes. When you suspect an aortic dissection, what will be your first investigation of choice? Okay.
CT.
CT.
No, I what for aortic dissection?
And okay, I would take CT. See, that's what. See, we all do things. Okay. Only thing is, we don't know what thing to do when. So, what are the adjuncts in primary, and what are the adjuncts when these things should be weight and like when what to be given prioritized. Okay, so that's the thing. Otherwise, it's all good. I like the way you presented the things. Only thing is, you didn't notice a very small. The patient is collapsing, what to do next, and you didn't prioritize. That's the thing. Otherwise, it's a good thing. Okay. And anybody okay, I'll point out Avantika.
Yes, ma'am.
Avantika.
Yes, ma'am.
Yeah. Can you tell me what will be the X-ray findings for Borevs? I told you some. Can you add up anything? Any points?
Pneumomediastinum.
I told already, okay. Say something. Signs. Pneumomediastinum is not a sign, it's a diagnosis. Just to tell what you want. Like, see, there is air in the thorax, okay? There is air which has been leaked from esophagus. Where do you expect the air to be like escaped into? Just put your thoughts into it. People, the question is for
Yes.
all. Please open up. I got nobody have a brain here. Hello?
Yes,
Am
ma'am.
I on the call? Hello?
Yeah, yeah, you're audible.
Hello.
Yeah. People don't muck up things, okay? You're going to forget things when you muck up things. I'm just asking you. See, the esophagus has been ruptured, the air has been leaked. Where do you expect the air to get, like, go into?
There will be subcutaneous emphysema,
Okay, it went into the skin. Before that, the skin is so upper.
pneumothorax,
Okay,
Wait,
pneumothorax. How? Okay, pneumothorax. Uh huh. It's a pneumomediastinum. Screw the pneumothorax. It's a thorax. It's a mediastinum. What is there in the mediastinum, people?
pneumopericardium,
pericardium.
Okay, heart. Okay, pericardium. So, I'm fine. I'm done. Okay, please just go to any website or something, see the X-ray and compare where all the air has been leaked and what it have done. Okay, fine. That's it. Why there is pleural effusion in Borehef's, like, in this kind of a thing in X-ray? Left-sided, especially left-sided pleural effusion. Is there any significance? Okay, look up, look up. What is the mortality of Borehef's percentage? Okay, it's like dragging you people. Okay, Sami, it's a good thing. It's a good case presentation. And try to complete it within a given time and go systematically. Always it's A, B, C, D, E, what you do in A and what you do in B and C. And always have a DD. If you don't even have it, try to finish. Try to have like one or three, and like give your investigations accordingly to that. Otherwise, I'm done. Do anybody have questions? Do anybody have any questions? Sir, can I wind up the class?
Yeah, you can wait.
Thank you. Thank you all.